goal today is to, again, give you practical knowledge that you can walk out of here feeling like you have some confidence when you get into your renewal for this fall, that you kind of know what it is that you're looking at and you're a little prepared for what the process is going to be like. Because for many of you, especially in the small group, the process is going to change. So what we're going to do is we're going to start out today, we're going to talk about the mandates on the insurance carriers, because these are significant, these are all kicking in, there's no delays. Then we're going to talk about the individual mandate, again, not delayed, still going forward. We're going to talk about the exchanges, then we're going to talk about employer mandates, then we'll probably take a break at that point. We're going to come back, we're going to talk about employee communication and required reporting and notices, and then we're going to spend probably somewhere around the last hour with a panel of Filice brokers talking about plans and rates. So, and that is literally changing by the hour. We're getting information by the hour. So I'm not going to get into really rates too much. I'm going to more talk about it from the compliance perspective, and then we're going to talk about what we've seen from our carriers when we get to the panel. All right. So to get started, the goals of this new law. Okay, so when they wrote this, there were three overriding goals of the Patient Protection and Affordable Care Act. So the first is guaranteed availability of coverage. No pre-existing condition exclusions anymore. They want everybody in the United States to be able to get coverage. Then when you get coverage, they want you to be able to keep it. So you shouldn't lose it just because you got sick. It shouldn't be taken away from you. So guaranteed renewability of coverage. And they want you to be able to have fair health insurance premiums. So all of those seem like pretty good goals. They sound like the way the insurance industry should work. But it's a big monster, big monster. So how are they going to make that work? You're going to start by mandates on the insurance companies themselves. So the first one is, and these are all already in place. So the first one is coverage for adult children. This happened, 2 renewals ago. You must cover children up to the age of 26. They no longer need to be students. It's not really relevant. This is nationwide, all size plans, all size carriers. So next they implemented the Patient's Bill of Rights. So these are all also pretty good things. Elimination of pre-existing conditions. It kicked in for children right away. It's kicking in for adults come January 1. No lifetime limits on essential benefits. So no longer will you have $1 million or $5 million cap for your lifetime. No rescission of coverage. So you can't take away coverage just because somebody gets sick or they make a mistake on an application. It can only be if you truly believe that they're fraudulent. No cost sharing for preventative health care, so 100% coverage when you go get your annual exams, your child immunizations. Limits on pre-authorization and cost sharing for emergency services, so they can't make you pay more just because it was an emergency. Choice of any available primary care physician, OBGYN, and new internal appeals processes for carriers and self-insured employers. So this is the Patient's Bill of Rights. This is already in place. This is a good thing. They all sound like good things. I think here in California we don't necessarily understand how significant these changes are, because most of these were somewhat already in place. It's some of the states, mostly in kind of the southeast, where insurance is much cheaper, but you get cancer and they can kick you off. And so that's where this is much more significant. And so when they talk about, we're going to talk about the press a little bit towards the end, when they report, that average rates are going to go up 30% or 70%, and a lot of these are in the states that did not have the consumer protections in place that California already had. So these are all good things. They're already in place in California and nationwide. In addition, no cost sharing for preventative care for women. Basically, we're talking about birth control, that sort of thing, is free of charge now. A uniform summary of benefits and coverage. That's those 6-page blue handouts, which sounds like a really good idea. And now the idea is that carriers can't hide things anymore, and so everyone's going to have the same sort of benefit summary, and you should easily be able to compare plans across the line. However, they're 6 pages long and blue, and so that's kind of an administrative nightmare. But those came in last year, so those are already in place. And then, of course, the medical loss ratio rebates are already in place. So that says that if you are a large employer, you must spend 85% of what you take in on premium on actual claims. If you're a small employer, it must be 80%. And if you don't spend that much on claims, you need to rebate it to your employers or whoever had the premium, your individuals or your employers. So, you know, pretty good. That, you know, we saw some activity with some rebates. I think it put some transparency in the process, which is what people wanted. So these are all the things that are already in place and already apply to all the insurance carriers. What is coming down the pipe, IRS reporting, these are actually proposed regulations. These were laid out with a little more clarity a few weeks ago. And what they're talking about is the reporting that the insurance carriers are going to have to do. And this is going to apply to all insurance carriers across the U.S. They're going to have to do annual IRS reporting to the IRS to state whether or not you all had coverage and who is on their plan and what they're paying and that sort of thing. And they're also going to have to get a statement to each of you that you can then use to show when you file your taxes that you have insurance like you're supposed to. So that sounds good, but the reporting is a little onerous. In fact, when they came out and they delayed the employer mandate and they said it's because they didn't think employers were ready and they wanted to give them a little more time, I strongly believe it had much more to do with the fact that the IRS is not ready. So what they're trying to do here, they just don't have the systems for, and it's almost October. So this is what we're looking at from a carrier side, and then we're going to talk about a little bit later about what the employer is going to have to do. But for carriers and self-insured employers, what you're going to have to do is an annual report to the IRS. This is going to be due by February 28th. Of 2016 for data starting in January 1 of 2015. So they need to have this in place by January 1 of 2015, and they're going to report on an annual basis the name of each enrolled individual, so you, your employees dependents, the last known address of the primary insured, and the tax ID number and months of coverage for each individual. So we're talking about Social Security numbers. They're going to have to report the Social Security number of each member to the IRS as of, for data, January 1 of 2015. Now, it would be my guess that many of you don't track Social Security numbers of dependents. And I don't, you know, each carrier's election form is a little bit different, but now these Social Security numbers, employees are going to have to give over the Social Security number of their children in order to have coverage for January 1 of 2015. And there's some valid concerns here about security, identity theft, that sort of thing. You're probably going to get a little pushback, but this is definitely coming into play for January 1 of 2015. And so if you have an HRIS system and this isn't necessarily something that you track, this will be something that maybe you want to roll out at this open enrollment, that let people know that this is coming, that they're going to have to do it. Now, when they communicate to the IRS, they are going to have to do full Social Security numbers. But when they communicate with you, statements to the individuals, this will be in January of 2016 for 2015 because you're going to need that statement when you file your taxes. They're only going to have to use the last 4 digits of the Social Security number. So they're trying to protect identity theft by mailings through the mail. But you're going to get each individual is going to get a statement with the policy number, contact information for the reporting entity, which is going to be the insurance company. They're going to tell you what they reported to the IRS on your behalf. And again, it doesn't require the full Social Security number. So these are the proposed regulations that are out there that insurance companies are going to have to do come January 1 of 2015. I don't know that I necessarily think there's going to be much changes to this. It kind of makes sense from a reporting perspective, but I don't believe that the systems are in place yet, or that anyone's prepared for this. So this will be something that will be of interest, and it will also be of what the insurance company is going to ask you to do versus what they're going to handle on their own to get the information that they need. But I would assume that come January 1, you're going to have to be able, on your census or whatever you give them, you're going to have to give them the Social Security numbers of all of the dependents. So it'll be something that you need to track. So these are still proposed regs. They're not finalized, but it gives you a pretty good idea of what's going to be required. So this is all insurance companies, small and large group. Everybody's going to have to do this reporting. All right, then we also have something called California's AB 1083, because, we're California, so we can't just go with the federal law. We have to come up with our own version. So for the most part, this is pretty much a duplicate. And it did not receive much fanfare because it seemed like a duplicate of the law, and the way it was written, it mostly applied to small group, or it was written so that everyone was assuming it was only applying to small group. And then, just a few weeks ago, the Department of Managed Care put out a little bulletin that says, no, 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 this applies to large groups. So where this is significant, pre-existing condition exclusions pretty much mirrors federal law, not really different. Eligibility can't be based on health status, not really very different, but we're going to talk about how underwriting is going to work. Guarantee issue and renewability, same as the federal law. A couple things though specific to California. One, marketing of plans must be available in all service areas. So they've said, okay, insurance companies, you can't decide not to offer your plan in a certain area because it's more expensive, inconvenient, whatever the reason is. Any plan that you have available, you must offer it in all service areas if you have providers there. So if you have a doctor there, you must provide that plan. You can't say we're not doing it in certain zip codes. But the big one is waiting period. So California in CA 1083 has come out and said you cannot have a waiting period any longer than 60 calendar days. Okay, this is a mandate on the insurance company. It's not a mandate on you per se, but the insurance company can't give you a plan that will allow you to have a waiting period of longer than 60 calendar days. And lo and behold, this applies to small and large group. So come your renewal, as of January 1 or later, the longest waiting period that you can have for benefits is either first of the month following 30 days, or you can do it on the actual 60th day, though I don't recommend that because I think that would be an administrative nightmare. So if you have a waiting period of first of the month following 60 days, 90 days, 6 months, everyone is going to have to change their waiting period if you're on a California plan to the longest it can be is first of the month following 30 days. You can be more generous. You can go data hire, first of the month following data hire, but the longest you can go is first of the month following 30 days. This starts on your renewal as of January 1 of 2014 or later. So what if you renew before? So if you renew in the next couple months, this doesn't apply to you. So it's renewals as of January 1. So this is one of the things, if you are a small group, and we're going to talk about early renewals as we go through this, and you have been offered an early renewal by your insurance carrier, it is because they want to, and they want you to avoid some of these mandates as long as you can. So if you don't have a lot of turnover and your renewal, your eligibility is first of the month following 60 days, I am not sure I would go with a 12-1 renewal, do an early renewal just to avoid a month of this. But if you have a massive amount of turnover and you've been first of the month following 6 months, early renewal may be something that you take advantage of. And so we'll talk about early renewal as we go through. But basically, this is what the insurance companies are trying to avoid by having you renew 12-1. So renewal on or after January 1. This is a mandate on the insurance company. It's not a mandate on employers. It just happens to be that they won't give you a plan with longer than 60 days as of January 1. So when your next renewal on or after January 1, your longest waiting period can be first of the month following 30 days. Another set of mandates that are coming into play, and this time we're just talking about individual and small group. And again, mandates on the insurance company. First, insurance rate review. This is already in place. This has been relatively successful. What they've done here is they've said, and we've talked about this a couple earlier seminars, what they've said is insurance company in the individual and small group market, if you want to have an overall rate increase of 10% or more, you need to get that reviewed, not approved exactly, but reviewed by somebody at the state or federal level. So in California, the Department of Managed Healthcare is running with this process. Interestingly, we're one of only 17 states that doesn't give our insurance commissioner the right to deny health insurance increases. Really, all they can do in California is shame them into it. And so when Anthem would come forward and say, they're going to put out a 34% increase on the individual market, and the Mercury News blasts it all over, and then they come back and say, oh yeah, there was an underwriting mistake on a spreadsheet, and we're really going to only raise it 9%. That's what they're doing with this. And so this has been relatively successful. The first year it was in place in 2010, they had like 77% of proposed increases were over 10%. Now we're down to the low 20s. So a lot, the insurance companies are asking for less of those big increases. So this has been relatively successful. Essential health benefits coverage. The other thing that this is coming into place on January 1 of 2014. This is another thing that if you renew early, they're trying to avoid. They have said that in the small group and individual market, every policy must hit 10 essential health benefits. So you must cover emergency care and ambulatory and maternity care and preventative, and so there's 10 different factors. And then at each state level, they decide what level of benefits within those 10 factors. And so in California, they use the Kaiser $30 HMO as kind of their benchmark for saying at what level that you need to be for all those benefits. Again, in California, I don't know that this has necessarily been all that significant because, you know, in the group market, you don't have plans without maternity coverage, that sort of thing. But that is one of the reasons that they're talking about increases in the small group level, is that they're going to have a standard level of benefits. So there shouldn't be any surprises. No one should buy a plan and find out after they're pregnant that doesn't have maternity coverage. So this should all be standard. So this is coming into place in January 1. Again, we're just talking about small group. And then insurance premium restrictions. So they're saying, okay, in the individual and the small group market, your underwriting, you can't do it based on gender, health status, that sort of thing. So underwriting is changing significantly. So let's talk about what that looks like. So what they've said is insurance carriers, and this is all across the nation, in the individual and the small group market. Small group, we're talking about under 50. So you're under 50 employees, you're on a small group plan, you're age rated, you will continue to be age rated. For those of you that have maybe creeped over 50 employees and you're still on an age rated plan, for the most part you can stay there as long as you want to, and as long as you meet all of the underwriting requirements, you can stay there. And so they're changing the underwriting significantly. And then when I say significantly, I mean totally. Throw it all out. Throw it all out, no joke. So if you renew early, and you've gotten an early renewal packet from Kaiser, Anthem, Shield, whoever, and you renew 12/1, you keep your RAF, and you probably can keep your plan. You'd want to go through that with your broker, and you may not see such a significant premium increase, or that is the idea anyway, though we haven't gotten full renewals on most of our groups yet. But when you renew, come January 1 or later, underwriting is completely changing. There is no more RAFs. There's no risk adjustment factors. It's going to be based solely on 3 factors: age, family size, and geographic area. So when I say age, interestingly, what they have decided to do is they're having community rating, meaning that every person in the family is going to have a different rate. So the rate's not just based on anymore on the 43-year-old male that works for you. Now there's a rate for that 43-year-old, then the spouse, whatever age, then each child will also have a different rate, up to, I think, 3 children. I think if you have 4 kids, your 4th one's free. So it's been a fascinating process as we get these renewals, and when you think about your contribution strategy, because it's changing completely. So you're going to have a rate on each person. They have also said that older employees can't be charged more than 3 times what a younger employee is charged. So a 63-year-old can't be charged 3 times more than a 21-year-old. So if the rate for a 21-year-old is $250, the maximum rate for a 64-year-old is $750. So that sounds good, but our general assumption is that if you have a lot of older employees, your rates are probably going to go down. If you have a lot of younger employees, you will probably see your rates creeping up so that they can compress those rates. So, and that's what our panel is going to talk about. They're going to talk about what they've seen at their renewals so far. So we're talking about age, then we talk about family size, that each person is going to have a different rate for that person, and then geographic area. And they have taken it, I think, from something like 7 geographic areas to 19. So now there's going to be 19 different areas. So we're actually going to show you a chart as we go through the panel. This is crazy. And we're trying to figure out ourselves how we're going to navigate this. And so even as we talk about your contribution strategies, I don't think when you're doing a new hire orientation for someone, you're going to be able to tell them what their rate is right there. What you're going to have to do is probably collect all their family information from them, and then there's all these charts. We're hoping that we're going to have a system that will help, but probably what you're going to have to do is then email your broker to get the rate for that person and what their options are, and then they're going to have to email you back and tell you what that person's options are and what their rates are going to be. It's not possible to put it in one Excel spreadsheet. It's just not, because there's set 19 rating areas, and then there's a rate for each family, and then all of the plans that are available. So this is totally changing. And then under the federal law, they've also said that you could charge a premium for tobacco usage, but California said, no, we're not going to do that. So, so no underwriting for tobacco use in California. So that was also in California's 1083. Okay, I make it a policy, and Ron can tell you this, I try to not have any sales up here, but I want you to know, if you are a client of Filice, we are studying this so hard. Like we had an hour-long meeting yesterday where we just went through like 6 of the Kaiser renewals that we had received so far, so that all of our people could understand exactly what you're seeing on every page. So at any point, you know, as you're going through renewal, if you are not, say, a Filice client, and you are not 100% comfortable that you understand what's going on, you can shoot me an email. You can send me your renewal. One of our people look at it. We don't even have to come bug you. We will look at it. Same thing, if you are a Filice client and you're nervous about anything, you just send me an email. So I didn't really ask if I could do this, but we are, I mean, like, we are really, this is huge, and we've got dozens of people that are really focused on trying to understand this, trying to be ahead of the game, because everything is literally happening every day. So, like, so far we have Kaiser rates, we have some of our Kaiser renewals, we've sort of seen Blue Shield rates, we've seen some spreadsheets that say if you early renew, your percentage is this, if you renew January 1, but we haven't actually gotten a renewal packet that tells you what happens to each employee. So there's a lot of stuff that's going to happen really, really fast. And so this is definitely the year, especially if you're in small group, that you're going to want to make sure that you're on top of it. So now I want to jump to the individual responsibility. So that's pretty much the mandates on the carriers. Those are definitely going forward. No delays on that. So now I want to talk about the individual responsibility. There is not a delay on this. The law says that come January 1 of 2014, this January, if you are lawfully present in the United States, meaning that you show up on a tax return somewhere. So if you don't show up on a tax return because you're undocumented, you're still falling through the system. But if you're here but you're not a U.S. citizen, so you're on a visa or work permit or any of that stuff, but you still are filing a tax return, you are still supposed to have an acceptable level of coverage come January 1. And I say tax return because that's how this is all going to be tracked. It's all going to be tracked as part of the federal tax return process. So during that process, you're going to certify whether or not you had coverage. If you did not, you're going to pay a penalty. You're going to pay a tax. So you're either going to have to pay more out or you're going to get less back. So that is how they're going to track this, is through the federal tax return process. And that's why the IRS right now is so critical to this process. So as an individual, you could be on your traditional employer plan. All the employer plans that are going to be offered are basically going to qualify. We'll talk about that. You could be on an individual plan that you already had in place, though all individual plans are basically being terminated, and then you have to re-elect come January 1. So, but you could stay on any individual plan that you have. You could also be on a government plan, so it could be Medi-Cal, Medicare, TRICARE, any of those government plans. Those will all also qualify. Or you could get a plan through the state exchange. If you don't choose to do any of those options, you haven't broken the law, but you're going to pay a penalty when you do your taxes, and those penalties are going to help support the rest of these programs. So let's say that you can't afford to have insurance coverage, and that's why you don't have insurance. There's going to be 2 forms of subsidies. So the first one is there's going to be an expansion of Medicaid, or in our state, Medi-Cal. So this was one of the things that was part of the big Supreme Court decision, was that part of the law, the way the current administration had wanted to do it, you could get extra Medicaid dollars for your state if you put in a state exchange. And the Supreme Court said, wait, we like all those programs, but you can't, under law, tie the 2 of them together. So each state has 2 choices to make. Do they want to expand Medicaid in their state, and do they want to have the exchanges? California is moving forward with both. So Medicaid in California is Medi-Cal. And right now, currently, if you make up to 106% of the federal poverty level, you cannot, as an adult, get coverage through Medi-Cal, but you can for your children pretty easily. So that was the Healthy Families program. Healthy Families has now been absorbed into Medi-Cal, And it has been, if you were sort of the working poor, you're working for minimum wage, you could get coverage for your children, but it was never very easy to get coverage for you as an adult. Well, now that's changing, and Medi-Cal is going to, come January 1, cover those who make up to 138% of the federal poverty level. So this is people that are making $15,800 as an individual or $32,499 for a family of 4. So there's a chart that you figure this out with. And so the idea is people that are making minimum wage that should be able to get increased coverage through Medi-Cal. Now, interesting, in California, there's always money left over. There's a lot of people that don't take advantage of this, but this is how your employees that are, say, making minimum wage, this is where they could get coverage, is through expanded coverage through Medi-Cal. And they're trying to make it much easier for them to get enrolled by making it available through the exchanges and that sort of thing. So those are the subsidies that are happening on a state level. So many states are doing the increase in Medicaid, Medi-Cal in our state. Not as many are going forward with the exchanges. This program is being primarily paid for by the federal government. So it's being all paid for on a federal level for the first couple years, and then it goes down to the federal government paying 90% of the cost. So it isn't much of an increased cost on a state level outside of administration. So if you make up to 138% of the federal poverty level, you can get free coverage through Medi-Cal. And it doesn't matter whether or not you have an employer plan. It's all about how much you make if you can get increased Medi-Cal coverage. Now, if you make over 138% of the federal poverty level, but less than 400%, and you don't have employer coverage, you could get a subsidy through the exchange. So how those are working are sliding scale subsidies, and I'm going to show you some charts where, based on how much, how little you make, you get more coverage available to you. But $400,000 federal poverty level is somewhere around $92,400 for a family of 4. So seems like a pretty good income, though. In the Bay Area, of course, it's very expensive to live here, and insurance is expensive. So if they do not have available employer coverage, you could go to the exchange and you can get a subsidy through the exchange if you make up to somewhere around $92,000 for a family of 4. And I have the charts that explain all this. Be really careful telling any of your employees that they would be eligible for a subsidy, because you just don't know. That is between them and their tax professional. And I say that with a little derision because most low-income employees probably don't have a tax professional, but you do not want to be there. You do not want to have an email somewhere where you have told them that they would qualify for the subsidy or that they shouldn't get on your plan. You want to be really careful about that. So that is between the employee and Covered California and their own tax form, whether they're going to be eligible for that. And you'll see if you get on the exchange, and I'm going to talk about what I saw yesterday, that they'll tell you, oh yeah, you'll qualify for this much, but there's a whole bunch of fine print there. So it's on adjusted gross income, and you're not going to know what that is as their employer. So if you make up to somewhere around $92,000, you could get a subsidy through the exchange, and these are going to be in the form of tax credits that are applied ahead of time. So you would get it right away. So if you pick out a plan that costs $500, the federal government's going to pay $250, and you're going to pay $250. So right then, so that tax credit is given to you right at that time, and it's going to be paid to the exchange. But if it turns out at the end of the year that you were getting that subsidy the whole time and your income did not qualify, you will be penalized and have to pay that back in your taxes. So there's definitely going to be some confusion there, and you don't want to be part of that. This is if you don't provide employer coverage, the subsidy. Now, let's say you do provide employer coverage and they still want to go to the exchange. They can go to the exchange, but they're not going to get a subsidy. And so far, there is no mechanism under valid tax law that allows an employer to take out money from an employee's paycheck and pay that premium for them for an individual plan. And so we'll talk about some of those. So one of the problems is, and we're going to get into what you're required to do as an employer, but basically you're only required to make it affordable for the employee themselves. You're supposed to offer dependent coverage, but you don't have to pay any. And a lot of employers don't. You have like 100-0. You pay 100 for the employee, you don't pay anything for dependents. Right now, the way the law is written, if you provide affordable coverage to that employee, anyone that's showing up on their tax return is then not eligible for a subsidy. So even if you don't make it affordable to the dependents, the way the law is written, you've still made it affordable. So those dependents would not get a subsidy. Now, interestingly, we have been told on a couple different fronts that they're trying to change this. In Covered California, in all of their communication, it's coming forward and they're being very positive about how they're going to make this work for dependents, but we have not seen it in writing or on the tax code, so it is a problem. That it, the affordability. Now there is some stuff in there about, if they won't get penalized if it costs more than 8% of family income, then they won't be penalized. But you as an employer really should not be part of those discussions because you don't know what their income is. It may also depend if they're married or not, who's showing up on a tax return, divorced couples, what tax form it shows up on. So this is going to be pretty complicated for some people. But yeah, right now, if you make it affordable for the employee, then the dependents do not qualify for a subsidy the way the law is written. So we're hoping to see changes on that, but we have not seen it in writing. All right, so that's kind of how the subsidies are going to work. So how is this looking in California? So Covered California has come out. They've done a lot of studies on this. They've said that somewhere around 5 million are uninsured in California. I put 5 million-ish because that is 14% of Californians. Another report has said up to 22% of Californians. So we have a lot of people uninsured. So they're basing it off the 5.3 million are uninsured. In California, they estimate that 1.4 million will be newly eligible for Medi-Cal, and there's a lot of reasons why this actually saves us money, and the more people of those people that we can get on Medi-Cal, so there's going to be a big push towards that, and that they say 2.6 million would qualify for subsidies on the exchange. So there's going to be a lot of communication that is happening around this. A lot of money is being put into getting these people enrolled, educated. You're going to start seeing billboards, flyers, mailers to the home. In the Bay Area, they estimate we have somewhere around 390,000 people that would be eligible for subsidies through the exchanges, and primarily those are Latino and white. So you're going to start seeing a lot of billboards in English and in Spanish. There's something called assisters. These are people that are kind of between an insurance broker and the exchange, where they just advise people. Actually, they don't even advise. They help get them enrolled on a plan in the exchange, but they're not allowed to advise them. I can see these people kind of hanging out at hospitals like Valley Med. You show up with a broken arm, you don't have insurance, they'll be like, oh yeah, the doctor will see you, but go talk to Sally for 10 minutes. And they're going to try to figure out who you are, what your social security number is, and how they can get you enrolled in a plan. So there's going to be a lot of activity around this the first year. But like I said, right now the current programs that are in place, there's always money left over that people don't get enrolled, so there's still a big communication curve that is going to need to be addressed. So in our state, our exchange is called Covered California. It's coveredca.com. It's a nice site, very pretty. They do it in like 10 languages, so you can get it in all kinds of languages. What we have, there's estimated cost calculators, that sort of thing. What we haven't seen are specific plans and rates until sometime yesterday afternoon. So yesterday afternoon, they popped up the plans and rates calculator. You can't enroll yet, but you can get an idea of what is available. So I got on the site and I typed in that I had a family of 4, that I made $66,000, that one adult was 40 years old, one adult was 43, and we had 2 kids under the age of 18. And it popped up that my subsidy would be $590 per month. It then let me put that in $590 towards various plans to help pick out the plans. Now, one of the things that was confusing to me, as my understanding this whole way along, was that the subsidy was based on a silver plan. Well, it looks like it's going to let me put that $590 towards any plan, bronze, silver, gold, or platinum. And that's how the plans are going to work. So they're falling into 4 metal levels. Bronze, silver, gold, and platinum. So a bronze plan, lowest plan, is supposed to cover 60% of expenses. The silver is 70%, the gold is 80%, and the platinum is 90%. So how they're doing that is they set a specific geographic area, but this year at least it's the whole state of California. And they're saying, okay, if you are a Californian, what is the average amount of medical expenses that you would occur in a given year? And so then they had to design these metal levels so they would hit those various percentages, 90, 80, 70, and 60. And 60% is the lowest plan. And so the idea is that the insurance carriers would then that are going to participate in the exchange, have to match their plans to those metal levels, so that 60%, 70%. So let's say you're going to pick out, you've got about, this says if I go with the Silver plan, the Anthem multi-state plan, enhanced Silver 70, it costs $1,070 a month. With my $590 tax credit, it's going to cost me about $480. So let's say I think, okay, I can spend about $480. Then across that silver level, I should be able to look at all the carriers that are participating. So Kaiser, Anthem, Shield, HealthNet, and all of the plans should be essentially the same. There shouldn't be anything hidden in the fine print because they have to meet all of those 10 required medical coverage factors. And so then the idea is that you can look all the way across. So I can see that the Anthem Plan Enhanced Silver 70 is $1,070 a month. The Silver 70 HMO is $1,081, kind of like that. You're supposed to be able to compare all the way across. So anybody can go there. So what we're going to see a lot of, I think at first, is a lot of people that are not working for an employer and they've been denied individual coverage because of some medical condition. And no joke, medical condition could have been a rash. So it's been very hard to get individual coverage in the past. So now there's going to be no more pre-existing condition exclusions. Everybody can go on and get coverage. So people who have their own businesses, independent contractors, that sort of thing, that's who we're going to see on there. Again, there's no income restrictions to get coverage, just to get the subsidy. Also within Covered California is going to be something called SHOP. SHOP is for small employers. So it's a small business health options program. So the idea here is that small employers can go on and they could get coverage instead of going directly to one of the carriers through a broker. They could go on the SHOP to get coverage for their employees. You can still use a broker or not. You can do it however you want. The thing is that the rates in the plans inside the exchange are exactly the same as the plans outside of the exchange. So there's no money savings there. The two benefits may be, first, the small business tax credit for health insurance is now only going to be offered to employers that go through the exchange. But this small business health, or this tax credit that was available, is only for employers that have less than 25 employees and they average less than $50,000 in income, which we don't have much of that in the Bay Area. So we haven't seen a lot of traction with that. But if you think that is something that you could apply for, that would only be if you go through the SHOP. The other area that the SHOP may be of value is that they're not going to have traditional participation requirements. So right now, if you have, say, Anthem sitting next to Kaiser, Anthem is going to want somewhere around 50–60% of your population. Well, now if you were to go through the SHOP, you could get one bill on one plan, but you could have 14 people on Kaiser, 6 on Anthem, that sort of thing. So there are not supposed to be traditional participation requirements. I would tell you, and we're going to ask our panelists this question, this may be a really good option for you in June or next January. But based on the process that brokers have had to go through to get our training and stuff, I am not trusting necessarily that the system, that you're even going to get your cards. So my personal opinion on this, definitely something you should look at, something that your broker should be paying attention to, but I don't know that I'm recommending that anybody jumps on this come January 1, because we just don't even know that the systems are going to work. And it's not you get the same plans and rates in the exchange and out of the exchange. There's also going to be some limited networks, meaning that if you get a plan through the SHOP, you don't necessarily get the same network as a plan that would be outside of the SHOP. To get the tax credit through the SHOP is for you have 25 or less employees and they make on average $50,000 or less. That is of their wages, and that is to get the tax credit. But if you are an employer of 50 or less employees, you can go through the SHOP to get your plans. And so we'll talk to our panelists more about their recommendations with that as we go. All right, so that's Covered California. It's up. For better or worse, California has embraced this. We are the farthest along of anybody else. We've got some very smart people working on this, so hopefully it all keeps going together. So what do these plans look like? And I'm trying to get as much information on here to be clear, but if you can't really see it, I can send you the PowerPoint. So what do these plans look like? So these are standard plans for individuals. So I put up here what the key standards are for bronze, silver, gold, and platinum. So if you're on a platinum plan, there's no deductible, no cost for preventative care, $20 to go visit your primary care physician, $20 for lab testing, co-pays, $150 for imaging, out-of-pocket maximum of $4,000 for a single. So this is a nice plan. You're also going to pay for that nice plan. But if this is what you want, it is available to you. The gold is going to have a $30 copay. The silver plan, once we get down to the silver plan, there's a $2,000 medical deductible. Again, no cost for preventative. You're going to pay $45 for a primary care physician, 20% for high-cost services if you go in the hospital, out-of-pocket maximum of $6,350 for an individual. So if you go to the max. Now, if you want you want the bronze plan, you're going for the cheapest plan possible so that you can meet the requirements. What you're going to be looking at is a $5,000 deductible for medical and drugs. Again, no cost for preventative care. You get up to 3 primary care physician visits at $60 a piece that don't go into the deductible. So if you just go for your preventative, you get a cold one day, you're good on that. But if you want to see a specialist, it's $70 subject to the deductible, 30% for lab testing, 30% for high-cost services. So these rates, again, are going to be based on age, family status, and their personal zip code. So this is kind of how the plans lay out. So they're not, that bronze plan, it is not a beautiful plan. But if you just want to meet the mandates, you want to make sure you have catastrophic coverage, this is kind of what you're looking at. So this is basically, and there's a much bigger chart to this I was trying to simplify, but this is basically how the plans are going to look in the small group market. So what do those subsidies look like? So now I took a single person and looked at the silver plan. This would be those that are eligible for the federal subsidy. What it looks like is if you have an annual income of $15,800 to $17,235, you're going to pay somewhere between $19 and $57 a month for coverage. So that's pretty cheap. You're going to have a no deductible plan, no cost for preventative, $3 to go to the primary care physician visit, $25 to go to the emergency room, 10% for high cost services, maximum out of pocket of $2,250 for a single. So if you are very low income, but you don't quite qualify for Medi-Cal, this is a really nice option. I mean, you are getting a nice plan and it is being basically subsidized almost the whole thing by the federal government. So this is a good option. Our challenge here is going to be communication, getting people enrolled. But now if you make somewhere between $28,000 and $45,000, you're going to pay somewhere between $193 to $364 a month with a $2,000 medical deductible. Preventative care is no cost with one annual exam, $45 for primary care physician, $250 emergency room copay, and with the $2,000 medical deductible. So it's still a pretty decent plan that is being subsidized. It's not a total foo-foo plan. It's not that gold, or it's not that platinum plan from the beginning. But if you need a subsidy to help pay for this, you're getting some pretty decent plans. The question is really when you try to put this to a live person. So I was thinking about, let's say you're young and healthy, you're 28 years old, your goal in life is to be a professional snowboarder. So you're living in Tahoe, you bartend just enough to pay the bills so that you can get yourself on the slopes. So let's say you're making, somewhere around $28,000 a year. You're going to pay somewhere around, say, $190 a month for a plan that has a $1,000 deductible, $40 to see the primary care physician, $5,200 out-of-pocket max. Now, as someone that works in insurance, that seems to me like a really good deal. But when you take a $28-year-old snowboarder and you tell them they're going to have to pay somewhere around $190 for coverage, are they really going to consider that affordable, or is it going to be easier for them just to decide to pay a penalty? So that's really where the education curve is going to come in here. So how is it going overall? So these are kind of the exchanges. The blue states are the states that decided to go forward and have an exchange. The yellows are the ones that said that no way, they don't want to, and the lighter colored ones in the middle there are working with the federal government, and they're saying, okay, we're going to do part of it and you're going to do part of it. So clearly this is political. The vast majority of the states that are going forward are Democrat governors. The vast states that aren't are the Republican governors. They've had a little more uptake in the Medicaid expansion. Many of the Republican governors are doing the Medicaid expansion. They're just not doing the exchanges. West Coast, you know, if you've got employees in Nevada, Colorado, that sort of thing, they will have an exchange option. But in some of the other states, they're not going to have an exchange option. So if they're not on your plan or you don't offer them coverage, it's going to be a little harder. Now, right now, if you are not in a state that has an exchange and you need to try to get a subsidy to get coverage, basically you just go through healthcare.gov. So this will be interesting, you know, what happens in other states, what your options are for your employees in the other states. Now let's say you say, forget it. I don't want anything to do with this. I don't trust the government. I don't want to get a plan. What's it going to look like? What is that tax going to look like? So for 2014, if you don't have coverage for 2014, your penalty is either going to be $95 for an adult up to $285 for a family, or 1% of family income, whichever is higher. So if you make $50,000, your penalty isn't $95, it's $500. Okay, so it gets steeper as the years go on. So in 2015, it goes up to 2% of family income. In 2016, it goes up to 2.5% of family income. So they're not trying to put anybody in the poorhouse with this. What they're trying to do is gently nudge them into being responsible for getting coverage for themselves and their family members. Now, there are a couple things to this. You can have a break in coverage of up to 3 months and not pay a penalty. If you only lose coverage for part of the year, you would pay a prorated penalty based on the number of months you don't have coverage. They have also come out and said in the fine print somewhere, this hasn't gotten a lot of news, but that if you have employees that don't have coverage, but your enrollment is not on a calendar year, so you have like a June 1 enrollment, and they enroll in June, they won't pay a penalty for those months that they didn't have coverage for that first year, just this first year. So there are some loopholes to this. Almost everybody has to have coverage. There's some exceptions for like Indian tribes or churches that don't believe in insurance, and I forget what it's called, but they support each other. There are a few little exceptions, but not very much. And there is also an exception that you won't pay a penalty if the cost of coverage for your family is over 8% of your family income. But again, that is not a decision for you to make as the employer or to advise them about. But that's pretty much what the penalties are going to look like. So this is say, hey, you forget. And what's going to happen is that come January 1, people are going to be still largely oblivious about this. People that, you know, if you have employees that don't take your coverage because they feel that they can't afford it, which may be very valid, but you know, this whole idea, this $95 that's out there 18 months from now, and everybody in Washington fighting and all of this stuff, a lot of people are not going to pay attention until the penalty kicks in. And then they're going to come stomping in your office, you know, why didn't you tell me about this? I didn't know anything about this. You weren't really clear. So as we go through all of this, you know, you got to kind of think in your company, what is your philosophy or your approach going to be about this? Do you want to just do the minimum that you have to do and hope no one asks you any questions? Or do you want to be more proactive now, saying, hey, people, this is out there. You want to, you know, you need to get enrolled. This is the law. This is what you're going to need to do. And so that's why the second half we're going to talk a lot about communication, what your options are and where you want to go with that. And if you're one of those that says, hey, we got a lot going on, I'm just doing the minimum I have to do, that's up to everybody else, that might be a very valid choice. Every company is different and every employee is different.